Recording.
This meeting is being recorded.
Stan, we're live.
Hey, thank you, Larry, the Liberty Guy, that is. Good to be back with you all. This is Mike Stenhouse, host of In the Dugout, and welcome back for a special summer edition. Hope you saw. If you didn't see, just go to our homepage for our videos, rifreedom.org/live, and check out our last special edition with the critical race theory and the whistleblower teacher from Providence, Ramona Bessinger. You really got to see that if you haven't seen it yet. All right, today we're doing a little extra inning sort of again. We're going to spend almost the entire hour with Dr. Andrew Bostom. There's been so much talk about mandates for vaccines and masks. There's new pushes. There's teachers' unions involved. The hysteria is growing over this new strain. And the push, and I don't know if politicians are going to be able to resist. And it's ignorant pressure. And we're going to go through that with Dr. Bostom today about how also misguided. I mean, so we're going to talk about that in just a little bit more. Today, I'm in the dugout, so I'm going to go with my, you'll have to forgive me, Patriots fans, but I'm a Green Bay Packers fan. I'm unabashed. You guys know that. And we're happy because Aaron Rodgers, our MVP quarterback from last year, is back in the fold. So Packers will win the Super Bowl this year. You heard it right here. I'll take any bets. All right, we're winning the Super Bowl, and then the team's going to be gone, and we'll be a last place team after that, after everybody leaves. Okay. All right. On today's show, we want to try again. We know you have a lot of questions. It's confusing with all this direction, so we want you to call in. All right, we know people are a little bashful about zooming in, showing their faces. So you'll see on the screen, there's a dial-in number. You can dial in, and we can put you on hold. And we're going to bring Dr. Andrew Bostom on in just a few minutes. And we're going to talk about this. Let me show you this. You might have seen our graphic in promoting our show. But it really is kind of, I think it kind of captures the mood out there. Mandate madness. Which mandate are they going to try first? Which one is going to get the most legs? Which one is going to advance? Which one is going to be shut down by parent groups or concerned citizens? Which mandate will prevail? Because they're coming, folks. They're coming. America is on the verge of. I hope it's just going to be a fight about mandates. Well, mask and vaccine mandates. We don't believe there should be the one. I hope we're not going to get to the point where we're locking down again and all that. Sheltering in places. All these new terms we learned, but they could be coming. All right, just a couple other comments on a few other areas before we bring on Dr. Bostom. First of all, there's all this. You've heard all this talk about the fight between Governor McKee and Mayor Laza, and that has to do with the basically the teachers' contact. It was supposed to be a press conference about the water fire, but it ended up having a shouting match about the teachers' contract that the state negotiated. Don't forget, because Mayor Laza was so incompetent in his first 5-6 years as mayor, they took the schools away from him. He did nothing to improve the school situation in Providence. In fact, he was trying to shut down charters, and now it's all flipped. The state has now taken over the system, And now Mayor Lawser is upset that there's a teacher's contract that he doesn't get to see first. He's acting like a petulant child. Listen, I don't agree with the governor either, striking a deal that apparently is completely the status quo with the Providence teachers. And the Providence Teachers Union, I should say, we look at the union, not so much the teachers. We know the Providence Teachers Union are blocking all kinds of reforms in that city. And it's unfortunate for the students, of course. So, I'm not on Elorza or McKee's side, but Elorza throwing a little hissy fit out there yesterday. This is what he deserves. This is what he gets. He's been a failed mayor. I mean, you look at the crime in that city, you look at the shootings, you look at the fights going on, the motorbike and ATV madness that's going on there. Now he's talking about paying reparations, some of the most extremely radical Marxist ideas in the whole country. We've got an ongoing pension mess that he's done nothing about. They're talking about defunding the police, which is why all the crime is up. I mean, this guy has made Providence a disaster, and he's upset because the state negotiated a contract and didn't share it with him. The state took the schools away from you, Mayor Lorza, because you did nothing. Now, the state's doing a horrible job itself under McKee, and especially under education director with the critical race theory in Fonte Green. So more on that later. But again, the warning here, you might remember our guest from about 5 or 6 weeks ago from the Portland, Oregon area. And we were talking about how Providence appears to be on the same path that Portland, Oregon went down. So we will see what happens. All right, I also want to give you an update on Nicole Solis, the mother in South Kingston, who was threatened to be sued for asking too many questions about the curriculum her children would receive when they went into the South Kingston public school system. You might recall that after her interview with us, that great interview we did, we actually arranged through a partner of our center all the way out in Arizona, the Goldwater Institute. They have a very robust legal defense firm out there, no charge to clients. And we put Nicole in touch with them, and indeed, they are now representing her. In fact, they've been on Newsmax, they've been on Fox News, they've been on, there's been articles written about them, about their story. And I just want to give you a quick update on that. So the Goldwater Institute, on behalf of Nicole Solis, did put in an updated records request. But guess what? The school committee in South Kingston still corrupt. Still try, just like so many other government entities throughout the state and throughout the country are doing, their way of keeping you in the dark, of hiding information from you, even when you put in a legitimate public records request. Their trick now is to say, well, we'll do it, but it's going to cost you X amount of dollars. And I think the amount of dollars is, $9,000 to Nicole Solis. The Goldwater put in another APRA request, and they got I'll get the details, worse, a higher amount of money. So this is the trick these government agencies are playing to keep you in the dark about what's going on with the education of your children. But there's another issue that the Goldwater Institute, Nicole Solis, are working on, and that's an open records potential violation. In fact, the Goldwater, we're going to have a larger show on this in the coming weeks. But the Goldwater Institute has filed a complaint with the Attorney General's office that the South Kingston School Committee and a board, more specifically a board it created, they thought they could create this board, and therefore the board didn't have to satisfy open meetings laws throughout the state. That's false. They still do. But yet they tried to hide behind this board. Again, they're trying to keep stuff secret from you. Right? They are desperately trying to hide their push for critical race theory, gender equity, and all the other anti-American stuff that's going on in schools. So they have filed a complaint with the Attorney General's office. And once the Attorney General responds, we will have them on, and we'll do a larger story on that. All right, let's get into COVID. And let's bring on our expert, Dr. Andrew Boston. Andy, welcome back to In the Dugout.
Hi, Mike.
Yeah, we miss talking to you. We're on an abbreviated schedule, and listen, you've been the man, right? You've been right on about everything. You would have thought at the end of the spring, Andy, with the cases going down, that maybe all the hysteria was behind us, but it's not, is it?
No, no, absolutely not. And the CDC just poured fuel on the fire with their recommendations. They're totally counterfactual recommendations.
Well, they're counterfactual. They're contradictory. They're confusing. They change one week to the next. So this is why we're having you on today, Andy. Is trying to make sense of all this, all from the one guy. Well, maybe not the one guy, but the one guy we've had in Rhode Island. Anyway, you're the one guy in Rhode Island who projected what was going on, who has given us the accurate information. You've been proven true, even though they said you were the crazy guy, right? And all that. You've been proven true on everything. It's the cancel culture. If you don't go with the status quo, how much of that have you gotten? Let me just ask you that. How much of this what do I want to say? This cancel culture kind of pressure you've gotten for not going.
Well, I was canceled before COVID because of my scholarship on Islam. So it doesn't, I'm immune to it. It doesn't matter to me. It's and actually although this is more interesting because in that scholarship I was moving outside my formal training. And so here, being an epidemiologist and just basically discovering that moving from cardiovascular and kidney disease epidemiology and getting up to speed on infectious disease epidemiology, all I was doing was reflecting what was sort of standard thinking in dealing with pandemic planning not that long ago, Mike, really up through 2019. So it's kind of a shock to see.
But that generally accepted thinking on how to deal with pandemics, they've thrown that right out the window, right?
Absolutely out the window. And now that experiment has played out, because after all, back in February, March, April, May of 2020, it was an evolving situation, and even though lockdowns had been discouraged, you didn't know whether, in this case, somehow they were merited. Well, now we know for sure they were not merited. They did nothing to offset the burden of this illness. It is a very segregated illness. There's some interesting CDC data. It's quite a paradox, Mike, because the CDC hosts a lot of journals which often produce materials which totally contradict what their leadership says on practically every issue. But one I guess that it's not fair to say it contradicts, but it emphasizes a flaw in their strategy was a massive analysis of a hospital network in the United States, looking at patients admitted for COVID, patients who wound up dying from COVID. And the figures, they emphasize things that are sort of accepted now, but in a very dramatic way. So 99.1% of patients that died from COVID had at least one major comorbidity. Only 0.9% were absent some sort of condition that they could identify. Now, that doesn't mean they didn't have one, but they could identify in this large hospital network database.
Less than 1% of all deaths.
0.9%.
Where was this study done? Where was this study done?
This study was done through a huge hospital network and then published in the CDC. And moreover, Mike, 63% or so of the deaths that occurred in people who were so profoundly comorbid, they had at least 6 major comorbidities, at least 6.
Let's circle back to some of that stuff in a second, because I know you've got a ton. It's been a while, so you've got a ton of data to share with us. I kind of want to set the scene first. So here's what I'd like to do. You've been looking at this stuff on a statewide basis, right? You've been looking at this stuff on a national basis, and you've been looking at data on an international basis. So I'm gonna share my screen here in a second and take us through the a bunch of graphs and charts. I like to look at the ones on WPRI.com. And I want you to comment for their value in Rhode Island, and then very quickly, and then how does that compare to, just very quickly, what you're seeing nationally, what you're seing internationally? You know, if you have that. All right, so let's go ahead and do this. So here's a new chart they've got. So they're talking about substantial cases. That's a new one. That's like they're inventing things. And Rhode Island's in a substantial, not a high risk, but a substantial risk zone. What do you make of this new metric, and how does this relate to America? And
Mike, the problem we've been dealing with this for so long now, it becomes tedious. We really don't understand what this means, other than some positive tests, and even those positive tests could be at cycle thresholds that are not very significant in terms of relating to hospitalizations and God forbid deaths. And so
counting cases is just folly.
It's ridiculous, and
that's not the metric we should be worried about.
No,
right?
absolutely not. And we're still very flat in terms of hospitalizations, let alone deaths.
Let's go down to that. All these vaccine numbers, that's pretty much fat line. So, we see a little increase in cases. Again, counting cases is really not the thing. Deaths, here you can see that deaths are
most of the days there's been zero deaths. I mean that's the trend. I mean, all those blank spaces are zeros.
Yeah, all these down here are zero. Yeah. So and most days it's one. And listen, I don't know if you looked at the data, but I still got to assume that most of these people are very, very elderly, probably comorbid.
Exactly.
All right, here's hospitalizations. That's pretty much flat line, a little up and down over time.
Well, here's another interesting thing, Mike. And we again, I like to give kudos where they're deserved. For whatever the reasons are, Matt Allen has a relationship with an honest spokesperson at the Department of Health.
Yeah.
I'm always, his first name is Joseph. I never remember the last name, or I can't hear it well enough. So for example, basically covering the month of July, Mike, what this spokesperson revealed to Matt was that there were 73 hospitalizations total related to COVID, but when pressed to break it down, and so obviously they have some of these data, Mike, only 39 of those were admissions that were truly from COVID, as opposed to
with COVID,
tangential, incidental findings of testing positive, coming in with basically another medical problem. Out of those, so that's a huge drop, Mike. We don't know what that's almost 50%. Half. That's almost half.
Yeah.
That's almost half. It's just under half. It's like 47%, something like that. Within that 39, who you could call more bona fide COVID hospitalizations, getting to this issue of the so-called pandemic of the unvaccinated, out of those 39, 8, so 21% were fully vaccinated. 21%, not less than 1%. 21% were fully vaccinated, and moreover,
so 1 in 5 of people in the hospital
with real COVID or some COVID syndrome related to COVID were fully vaccinated. And the problem is that the other 31 out of the 39, they lump together partially vaccinated with unvaccinated and call them unvaccinated. Now,
not scientifically accurate.
No, the honest thing to do would be break 3 groups: unvaccinated, partially vaccinated, and fully vaccinated. Because the problem, I sent some slides. I don't know if you guys have a chance to sort through and show some of them. The problem with which an interesting study from Sweden showed, and it was published at the end of April, was that there is a real phenomenon where early after vaccination there appears to be an increased susceptibility to infection. So in other words, after the first dose, say, of an mRNA vaccine, in this case, in the Swedish example, from about a catchment area of about 1 million people in southern Sweden, there is an uptick in infections. It's a real uptick. It's transient. It goes away as the vaccine takes more effect. But it's not a factitious phenomenon. So the idea of lumping together partially vaccinated with unvaccinated is completely inappropriate. And where this fiction, you'll still hear it, and you'll hear it in angry and dumb local Rhode Island talk show hosts about the fact that this is purely an illness now being.
All right, we're going to get into that because I want to have that discussion.
But 21% in Rhode Island, Mike, is not less than 1%.
No, that is not. All right, so let's go. Let's share. Let's just show a couple more charts. I just want to set the scene, and then we're going to get into some of this really good discussion here. All right, so let me share. Let's look here. All right, so intensive care, is down a little, maybe just a little spike the last few days. We'll keep an eye on that.
Again, Mike, we'd have to sort through that in a way to understand whether those, because you can have a traumatic illness that puts you in the ICU and then test positive for COVID there too.
So again, we don't know. And then the positivity rate, while it's gone up a little, still well below the, what they call is the danger line, right? So no concerns really there, right? So, all right, now let me ask you this first. Again, we're just setting the scene for now. We'll get into some discussions here in a minute. Are these same trends, is Rhode Island typical to what we're seeing in the nation and what we're seeing across the world?
Yeah, so if you recall last summer, Mike, there was an uptick in the southern latitudes of the United States. Remember, in Texas, Florida, Southern California, in particular, those big states. And we're seeing some of that again. And it goes back to a phenomenon that was described 40 years ago by a great flu researcher named Hope Simpson. And he couldn't explain why it was. He just noted the phenomenon that there's these latitudinal trends, and there is this little shoulder. In other words, after the big uptick in the northern latitudes, where people understand it, in the late fall through the early winter, maybe into the late fall through the winter into the early spring, the southern latitudes, for whatever the reason, get this little shoulder. It's never as big as the northern latitudes, and that seems to be happening to a certain extent. Again, it's there's more immunity in the populations down there, both natural and vaccine acquired. Although the vaccine acquired may be wearing off a little bit, unfortunately. So it's being managed. Fortunately, for 2 out of those 3 big states, they have very good governors that are not willing to be intimidated and that are going to deal with this as a seasonal, almost already endemic illness.
All right, so vaccines then. We've seen the breakthrough cases. You're saying that in Rhode Island, 21 of the 39 are basically breakthrough cases, right? Where they're in the hospital, even though they're fully
no, 21%, but 8 out of the 39, 21%.
21% of those 39 are breakthrough cases, where they're in the hospital, even though they're fully vaccinated.
Clinical breakthrough cases, not just infections.
Okay, now so these are people who are getting sick, even though we're told if you get the vaccines you won't really get sick, really get sick. If you've been fully vaccinated and you're a breakthrough case and you become infected, we know you can get sick. Can you also transmit it?
Sure. And what we're finding is that if you look at England and at UK and at Israel, who are further along or further removed from when large swaths of the population were vaccinated, they're still getting, thankfully, they're still getting some clinical protection in terms of reduced hospitalizations and deaths, certainly in the vaccinated populations. Although, Mike, it becomes hard to sort out what you can really attribute to natural immunity or to vaccine-acquired immunity.
I want to get into that in a minute too.
But be that as it may, when it comes to infections, last week, at the end of last week, and maybe it'll be updated, maybe it was updated earlier today, or it'll certainly be updated by tomorrow. Last week in the UK, in their most recent batch of data from what's called Public Health England, so their public health service, the vaccine efficiency in terms of preventing infection, not in terms of preventing clinical outcomes, which thank God was much better. It was down to 1.8%. In other words,
Whoa. What do you mean 1.8%?
In other words, to give you the raw numbers, the way you get vaccine efficiency in terms of any outcome, but in this case infection, is you take 100% minus the fraction of the population that's getting infected over the percent of that population that's been vaccinated. And so the raw numbers were something like, I think like 91% were vaccinated in the above 50s. This was really happening in the above 50s where you'd want it to be protective. And I think something like 89% of that population were in the pool of recent infectees. And so,
wow.
So basically it was mimicking the size of the population that was vaccinated, but it was still 1.8% different.
Weren't we told that these vaccines were 95% effective?
Exactly. And that
you're saying they're 1.8% effective?
But this is factoring in the real world. People being vaccinated months ago, longer than the duration of these clinical trials.
Where was that trial?
I'm sorry?
Where was that trial you just cited?
This was just an observation. These were just observational data published from the latest update from Public Health England.
All right.
So in the real world, in real time, things change. The vaccine wears off. There are different strains of the virus, et cetera.
All right. So here's the question. Here's why I asked all that is the setup. So on the talk show yesterday, you mentioned on the radio talk show, there was this concern, cases are spreading again and we got to stop the spread. Therefore, we need everybody to get vaccinated, right? That was basically the gist. Another, in a written newspaper, journalist or a reporter, whatever, wrote, it was basically shaming Woonsocket for having a low vaccination rate. Oh my God, how terrible. Maybe we ought to line everybody up in Woonsocket and, whatever, and shoot them with the vax. My point is this: vaccines. If we don't agree that you and I agree that we don't agree with the rest of everybody else that stopping the spread and counting cases is the ultimate metric to be worried about. But even if it was, we are now showing, this data shows that vaccines do not stop the spread. Is that true?
Oh, absolutely. I think the data from Israel and the UK, which are ahead of us in terms of the schedule of vaccine, but now in terms of the waning of the vaccine, are pretty clear. So you really can't make that claim anymore. And Mike,
but yet we're vaccine mandates.
Of course. And what does that say to all the kids on campus, which is also an interesting situation I'd like to update you on. But let's get back to the Woonsocket example. This is the toxicity of the reporting, the lack of curiosity, and instead of being reporters, these are advocates. So this guy should have just come out at the beginning of his piece, which actually was more of an opinion piece. I did get it wrong, and I was corrected. But he should have come out at the beginning of the piece to just say, I think vaccination should be 100% of people who are eligible in the state, and then write his piece. So what he does is he and I'm going to have to round off a bit. I think I have the numbers if you have the slides I sent you, but just from memory, I think the vaccination rate, fully vaccinated, was about 45% in Woonsocket, and he's very concerned about Woonsocket. And yet in the last week update for infections in Woonsocket, out of its population of, I think, roughly 16,000 or something like that, 40,000 in Woonsocket, there were 29 cases, 29 positive tests. So I simply went to the website and said, okay, well, what about areas that have higher vaccination rates? Well, one of them was Barrington. And again, from memory, it was about 73% that were fully vaccinated in Barrington. But Barrington has a population of only 16.
Let me hold on. Let me share that Barrington slide so people can follow along. I did find.
Sure.
Just tell me which slide. I know you sent me a bunch.
I don't know, Mike. I didn't number them. You'll have to go through them.
All right.
But yeah, that's it. So there you go. So that's pretty close. So yes, about 16,000 people in Barrington vaccinated at a rate of higher. 70. I think it was 72.8. I made a typo. But in that neighborhood, there were 31 of these positive tests in this week period of the week of 7/11. Woonsocket had less positive tests in a population that's almost threefold larger. And this is the kind of lazy buffonishness that a McGowan goes through to chastise the people of Barrington. Now, one of the biological reasons for this difference could be that the waves that came through, particularly the last waves in the fall and winter into early spring, there may be more infections that occurred in Woonsocket. It's more tightly packed, and they may have more natural immunity, and that's why they can have a lower infection rate despite the fact that they're not vaccinated as much.
I still want to get to that natural thing in a minute, but I still want to come back and keep remaking the point I'm trying to make here. So let's look at those Texas lawmakers that fled Texas and went to D.C. They were all fully vaxxed, yet that was a super spreader event among themselves, and they even spread it apparently among White House staff when they met at the White House.
Right.
So again, just another example, right, of vaccinated people becoming infected and spreading the disease.
But Mike, let's look at the silver lining.
But stay on my point, but correct?
Yeah.
Okay.
But let's look at the silver lining so far, unless we're not being told things, which is possible. I don't see any high profile hospitalizations resulting from that event. Which is good.
I know, but my point being is all the radio host, apparently the Boston Globe columnist, and everybody else here so worried about transmission rates and cases on the rise again. But what we've shown, we've shown it just here in this 5-minute discussion. Vaccines don't stop you from getting infected.
Absolutely not.
Now, we also know that's not a big problem, thankfully, right? It's not.
Well, so far, Mike, the problem is it's a moving target. It's perfectly rational to assume that if it goes from being more protective against just simply getting infected to less protective against getting infected, then it may become less protective against allowing that infection to cause more serious disease, that there may be a continuum. And by the way, that's exactly why they're talking about boosters now and turning this into the realm of flu vaccination, basically.
Oh, yeah, that's a whole nother argument, but let me just wrap this up and we're done. So, going back to our theme for today's show, mandate madness, right? It's madness to consider the empirical and actual data that we see. And even on the radio show yesterday, he started the show by talking about all the breakthrough cases that are out there.
Yeah.
But yet, the left and the government and the media are still seeing vaccines as a panacea to case counts. And it's not, is it?
No, but it's worse than that in the case you may not want to discuss it. In the case of someone like Dan York, who went into this vicious diatribe yesterday, he was trying to attack and shame his fellow Rhode Islanders who aren't vaccinated, using his very, very thin veneer of understanding and knowledge. And that's just wrong.
I don't know if he was trying to shame them.
That's what I heard.
I heard that, hey, if they don't want to get a vaccine, that's their problem, but they're not allowed out of the house.
Well, okay, Mike, excuse me.
Here, that was his thing, right?
Yeah,
hey,
no,
if you get vaccinated, then you get punished.
There was lots of pejorative references to them. There was no understanding, really, of the fact that, of course, the thing that crashes all these people, and you'll see why they assiduously avoid it, is any discussion of natural immunity. Because why should Rhode Islanders be chastised when probably half the state has been infected? And I would bet that a lot of the people that have been reluctant to become vaccinated feel that they have natural immunity, and or understand that it's possible that people who have been previously infected increase their risk for adverse reactions to the vaccines. So it's kind of a double whammy. They don't really need them for protection, and they're just setting themselves up potentially for more adverse events. And so for a certainly in this area, a regional talk show host to have no understanding of that, no willingness to even explore it, and then chastise people, I think it's highly offensive at minimum.
All right, and then there's another piece here, right? That nobody seems to ever talk about. Let me make an AIDS analogy. We don't have a vaccine or a way to prevent AIDS, right? But we have a way to treat it.
Exactly.
So even if you get infected, even if the test is accurate and you are truly infected, we have treatments now that unless you have a severe comorbidity, you will very likely, not in every case, obviously, but very likely not get very sick and not die from it. Is that so? We seem to be equating positive tests with death,
right?
And that's not the case.
Let me extend your AIDS. I think it's a very good HIV analogy. One of the things that was learned through bitter experience with HIV was that you treat early and you treat aggressively. We're still very loath for some perverse reason to do that with COVID I'm not saying in everybody because it's overwhelmingly a mild disease, but in those subgroups that are high risk and identified, the obese, the diabetic, those that have cancer, those that are organ transplant recipients, instead of telling them to stay home until they become febrile or got even worse. In some cases, they tell them to buy a home oxygen pulse oximeter, and if they start desaturating, to then come into the hospital. What's done aggressively with HIV patients was to keep their viral load as low as possible, and if possible, have it be eliminated. Not wait until they presented with fulminant AIDS. I mean, so it's really perverse that these available treatments, whether it's monoclonal antibody cocktails or potentially ivermectin, other treatments, are not used aggressively, certainly in high-risk patients with early disease. It's awful. And now the panacea, the vaccine, is starting to wear off.
Yeah. All right. I'm going to talk about that in just one second. But one of our viewers asked, is ivermectin still sort of banned, from a ethical, not ethic, people still staying away because Trump might have mentioned it once, or hydroxychloroquine, or is that widely available?
No, it's well, in this country, it's still considered, marginal fringe in most respects. It is being studied. By the way, the small clinical trials, randomized trials that have been done with ivermectin are very promising, and they've been pooled together, and they look as if it could be a beneficial, certainly early treatment. Some are even using it late and showing some results. But the point is that the big Oxford Clinical Trials Unit has been recruiting for what I guess they'll call a more definitive study. But there's enough evidence out there, and there are a lot of frontline physicians using it empirically in this country and certainly in other parts of the world, and claiming that they're getting good success. I mean, it's hard for me to judge. I can look at the literature that's been published, and it does look promising. In terms of the anecdotal evidence, that looks promising too, but that's much harder to judge. The point is, though, Mike, it's a very rational paradigm to treat people early, and that's why I was glad you brought up the example of AIDS.
Yep. All right. Again, one more question before we get to this natural immunity and all this. But with the vaccines, we've spoken a lot about, and I don't think our minds have been changed about the folly of having K through 12 students, even college students, even anyone under 30. The risk reward value factor there is just not value proposition is just not good. But for the larger population, have you seen any? There's a lot more theories out there. You see a lot more headlines. I don't know if they're founded or not. That's why we're asking you. Do you have any greater concerns, just generally, let's say with above 30 populations, about the safety of the vaccine itself? I know we can't know the long-term impact yet because we haven't been in the long term, but for any reason, do you have any concerns about that?
Well, I just to give you the broader picture, the way I'm starting to view the vaccines, and it's been a big disappointment to me. We've talked a lot about
Disappointment.
Yes, we've talked a lot about the safety signal and how that was being minimized, and it shouldn't have been minimized. And I think that problem is still with us. So there's the safety issue. But when you look what I'm concerned about now, and remember, I'm open about this. I came from the fields of cardiovascular disease and chronic kidney disease epidemiology. So the last 18 months have been a lot of getting up to speed for me. But one of the things that I'm convinced of, which I did not know as a clinician and as a researcher, is the relative futility of these massive flu vaccination programs. And the data published in the most prestigious medical journals like JAMA, like the Annals of Internal Medicine, are quite conclusive that even in the target population of, say, 55 to 75, there's marginal benefit of these massive flu vaccination programs. But the point is that when you now look at the safety record, which you can get from the VAERS system, flu vaccines are very, very safe. The profile or the incidence of serious adverse events from flu vaccines are truly, truly minimal. What it looks like to me, unfortunately, Mike, and especially now you hear this talk of boosters, it's a very open talk with the COVID vaccines, is that you're getting a rapidly waning effectiveness, and you've got a much worse safety profile than the flu vaccines. And that's not a nice profile. That's not a profile that gives one, a lot of comfort and optimism.
So so are you saying?
And it's coming at the expense of promising therapeutics, which makes it almost infuriating.
So you were saying it in all populations or just in younger populations that the COVID vaccine is significantly
Where do you think
dangerous than the flu vaccine?
Mike, these breakthrough cases that are winding up in the hospital are the same high-risk groups from the beginning in terms of COVID. So they're going to be the elderly and the comorbid. But the point is, and then the infection rate is just, it's just out of control. Although since we never tested for flu like this, we probably would have seen the same thing with the flu vaccines. In other words, that ostensibly the argument was they were keeping people out of the hospital. They didn't really discuss the issue of spread as much. It turned out that they're not really keeping elderly people out of the hospital. They're not really reducing mortality. But I'm sure if we had done all this PCR testing with flu seasons, we would have seen a lot of spread, obviously, in the people that were vaccinated. So see, this is the problem, Mike, and I'm not proud of my lack of understanding of this 30, 40-year history of flu vaccination when I was so focused on other things. But when I was active clinically, if I had an elderly person that certainly had cardiovascular disease, I would recommend that they get the seasonal, flu shot, and people may still opt to do that because it's got such a good safety record. But the benefits are truly marginal. I'm afraid now that we're moving into potentially the same realm with yearly COVID shots, and they have a much worse safety profile than the flu vaccines. So it's very concerning to me, and that's why I think that it's no longer a trivial issue to consider natural immunity and to consider therapeutics given early.
All right. Let's also consider the population of people who have been infected and recovered,
right,
who are now, because of these, quote, vaccine mandates or passports, are now themselves going to be forced or face consequences, or if others get their way, more consequences. So let me share this. You sent this.
And let's also bear in mind the magnitude of that population, Mike. That population could be half the United States now.
Yeah, so should people get vaccinated even if they've already recovered from COVID-19? Health agencies and medical experts are saying yes.
Mike, you recognize this because you're a Twitter user, but this is what they put in your face on Twitter as what's trending. In other words, they make up a statement. It's incredible, Mike. You understand this, but people don't. They make up a statement that the ideologues, typically from the left, support, and then they stick it up as if this is it. This is what you should know.
All right, so it's a made up. But what about the truth of it? If you've recovered, compare the natural immunity you might have had even without the virus.
Right.
The antibodies you developed if you had the virus, compare those three scenarios with the vaccine. So talk about those three scenarios. So for people out there who aren't fully vaccinated, you can give them some guidance depending on which category they're in.
Right. So the evidence is overwhelming now, Mike. That
Overwhelming.
It's really overwhelming, and it's coming from all different ethnicities, countries, populations. Where, so for example, if we look at a large study done in Sweden, and some of the studies actually you can directly in the same study compare vaccinated to unvaccinated with or without immunity from prior infection. And so, for example, in Sweden's early vaccination experience, which a report came out from southern Sweden, which involved about 1 million people, but they had a large subgroup that they could directly compare of people who were early on vaccinated and people who had had a prior infection but were not vaccinated. And looking forward at that group over at least a 2-month period of follow-up, which is not long, but it was an observation period that's quite consistent with vaccine trials, that the infection rate in those who had not been vaccinated but had been previously infected was about 33% lower than those who had been fully vaccinated. And also the interesting thing about this study, if you do have the slide in there, you might. You can see that this phenomenon of an increased risk for infection early after the first dose of vaccination was quite real. They were actually able to show it in this Swedish cohort.
Is this the slide here? Yes. So if you look at the green that I colored in there, if you look at there's an uptick after the first dose going from the baseline, and this is all expressed, I believe, per 100,000 or something. Yeah, per 100,000. And you look at that increase going up from 294 to 398 in the early period after vaccination. But then when you look and when you compare the fully vaccinated down in the blue circle to the unvaccinated but previously infected, you see there's about a 33% lower rate of infection. They're both low, and that's good. But certainly there's no advantage, in this scenario. And this has been repeated where prior infection. Right, so let me just translate this in English. You're all right. You go fast and you're good, but I want to get it straight in my mind. So the red below shows a 28 per 100,000 for people who were infected and who recovered. And were never vaccinated. Did not get a vaccine. This is where basically a rate of getting reinfected. A new infection, exactly. Right. So that shows that that your antibodies are really working positively. But that's lower than even people 7 days after their second dose. So that's right. So you're showing this as proof that the natural antibodies are more effective than the vaccine. At least as effective and potentially more effective. At least as effective and potentially more effective. And certainly when you think about the cellular immunity that you get, the T cell response, which is more robust, more flexible, and longer lasting. We know from SARS-CoV-1, Mike, that when they started testing and bringing them in for curiosity, for trying to understand SARS-CoV-2. That wave took place basically in 2003, and the early studies in 2020 of those patients showed that they were still immune. I know they still had T cell immunity. You might have had whether or not you T cell immunity, something you might have had whether or not you contracted the virus, or is it something? Well, that's another interesting thing. There are a number of confirmatory studies which show that even people
who they don't capture in terms of having antibody positivity to SARS-CoV-2 can still be, so they're called, quote, seronegative, though they can still have robust T cell responses upon appropriate testing, which means that
They've always had that. They've always had that immunity.
no, they responded to the virus, but it was so well
Oh.
contained. They were not only completely asymptomatic,
Okay.
they don't have a high antibody titer, and
Okay.
yet they still have a pretty robust immunity. As far
So
as
antibodies are as, if not more effective than the vaccine, and T cell.
well, it's not just
is
it's
even
Mike.
stronger than that, right?
It's not just antibodies. In other words, when you have a natural immune response, it's a fully orchestrated response. It's not just producing antibodies to a few to like the spike protein given in massive amounts. It's looking at the whole structure of the virus, attacking it in different ways, and also it's more of a stimulus to T cell immunity.
All right, let's talk children again. Parents are going back to school. Kids are going to college. I mean, parents are sending their kids back to.
I hope you can dig up my slide from Phil Kerpen, who nailed the CDC director.
Yeah, I have two. So I want to show you what she said first, then we'll show you the slide of the data. But first I want to show you this. So and kids are going back to college. So this is a statement that the CDC director, what's her name, Michelle Walensky,
Rochelle Walensky.
said, if you look at the mortality rate of COVID just this past year for children, it's more than twice the mortality rate
Yeah.
that we see in influenza in a
Unbelievable.
given year. Caitlin
Unbelievable.
Collins, I think, is that left-wing CNN reporter. But
Yeah,
anyway,
she put it out.
what about the statement from our CDC director?
Show the data. We have the
All right,
slide.
let's look at the data, and you can comment on it, Darren.
Yeah. I mean, it's unbelievable she would make such a statement every single year. And we're not even dealing with the last pandemic flu, where you see this number. Go, Mike, so you can scroll down to the 2012 to 2013 and
Yep.
show how big that number was in that particularly bad flu year. If you go all the way across 0 to 17, 1,161 versus in 2021, 213. And then we know from the CDC's own data, Mike, that 35% of these deaths are not really attributable to COVID. This is the CDC's own death certificate review. So really, the only numbers that are relevant are the 138 and the 81. And that's compared to all these flu years, all of which are seasonal. And then in 2009 to 2010, I believe there were about 1,300 deaths.
So the CDC director said that these two numbers here were twice as big as these group of numbers here. Does that look like these numbers down here?
Yeah, exactly.
They're about
Well,
1/10.
And these are all CDC,
1/10.
Mike, these are all CDC data. All these data are CDC data.
What explains this?
You'd have to seriously, Mike. At a certain point, you'd have to interview Rochelle Walensky. It's obviously you can make your own inference. It's being used to gin up fear and get people vaccinated. I mean that's the immediate impact of this, and its goal.
All right. So the bottom line is, we know that we've talked often in the show that the value proposition for young children, K through 12 especially, according to your research, the risk is higher with the vaccine of a problem there than it is with the virus, correct?
Oh, if you're talking about healthy kids,
Yeah, healthy.
because there's a very small, unfortunately, vulnerable subset of children, particularly kids with neurodegenerative disorders, developmental disabilities, and particularly developmental disabilities in conjunction with some chronic lung disease, where all bets are off. But you can see from those numbers, it's a very tiny fraction of the pediatric population of those newborns to 17 years of age. Healthy newborns to 17 years of age are at an infinitesimal risk from COVID, and therefore there's no need to vaccinate, especially now what we're learning about the vaccines. But regardless, there's no need to vaccinate other than a small niche population potentially of children if the vaccines were efficacious and maybe safer.
All right. Again, advice to parents I want you to give here. You just gave some on the vaccine. Let's talk for a minute about masks. The state has issued a guidance, again, following the inconsistent CDC that since the CDC is recommending that anybody indoors in groups should be wearing masks, whether you're vaccinated or not. And so certainly that would apply to schoolrooms.
And campuses.
Campuses. So that's the guidance. It's going to be up to apparently each school district itself. I don't know if the Department of Education has put out a directive. But if it is optional, again, we're not.
I don't think. Well, that would solve the problem, Mike. That would solve.
If it was optional, should a parent
no
have their children wear masks? In school?
Absolutely not. The damage from masks in terms of development and communication and just discomfort, maybe some CO2 retention, although that's whatever that may be a little controversial. Skin conditions. But just the fear factor, the terrorizing children again, absolutely not. And then, Mike, we've reviewed the literature ad nauseum. There's not a single randomized controlled trial of community masking that's ever shown they prevent respiratory virus transmission. And in fact, when it comes to kids, it's worse, Mike. They haven't even conducted one.
So when the CDC says there is evidence, even if it's a flimsy study, what are they using as the basis? What are these claiming is the basis?
They're talking about crude observational studies that are heavily biased, that often show contradictory results, by the way. Even these observational studies, like from Emily Oster of Brown University, the economics professor, she's published some studies that are purely observational studies that don't support the idea that masks are protective in children. But the point is, we can extrapolate from the significant body of randomized controlled trials in adults or 18 and above, including studies that were done on college campuses, all of which were uniformly negative between 2008 and 2020. The last one, the DanMask trial, was actually about coronavirus itself, COVID itself. All of these studies that involved 18,000 people were negative. That's the gold standard. When parents in the UK, back in the spring, before they came back into schools and the schools reopened and moved slowly from virtual to in class, they begged the UK government to do a quick RCT before the schools would formally reopen. It could easily have been arranged. The government refused to do it. The parents begged them, look, if you show us that actually is going to prevent infections in our children, of course we'll support. The government refused to do it. So if you look at the evidence that's available, the gold standard evidence being randomized controlled trials, it's uniformly null. I think I've said this before. I've never seen, as a clinical trialist myself, I've never seen a proposed intervention undergo 12 consecutive negative randomized trials and then be imposed upon people.
And so would you say that the evidence against masks in children is significantly stronger than the evidence for the case of vaccines for children?
Oh, in a sense, they're a little different. There's been no, at least in the case of vaccines, very short term, not enough safety monitoring, small numbers. They appeared to reduce these very mild infections. I don't even know if that's clinically meaningful, but at least there's randomized controlled trial data to show that. I think they came, even in those small trials, at a cost. If you look at the adverse event profile in these kids and compare them to the placebo groups, I'm not talking about things that caused them to go to the hospital, just pain and discomfort and everything else, which was probably worse than the little cold they would have gotten. But at least, okay, our endpoint is PCR positivity, and there was I think whatever it was, 20 in the placebo group and 0 in the vaccinated group over a short period of time. At least there's that evidence. What I'm saying, Mike, is that there isn't even a randomized trial that has been done in children, and we do have observations.
On masks, when you're talking about masks.
With masks. And we do have observations, for example, from SARS-CoV-1. There was an interesting report out of Hong Kong which showed that even the short-term masking they did then, remember, it was only about 3 or 4 months, there was really a lot of social isolation and other psychological issues that went on with kids.
All right.
So we don't even know this. I mean, this part of the suicide rate that's going up in kids.
Yeah.
All these things could, at least in some way, be
All the
related to the
unintended
mask.
consequences, right?
Yeah.
All right, last topic. We only got a couple of minutes now. You and I talked about this a little earlier. And again, even from the far right, even from the right, there's misinformation a lot of times. So make sense of this. Since this came out a day or two ago,
Mhm.
there's been a in the I don't know if you want to call it the conspiracy circles, but a lot of people read this stuff. A lot of people are seeing it, and it's about the accuracy of the PCR test. So let me share this post with you, and then I want you to tell us if this is just some of that false Twitter headline stuff, or whether you think there's some validity or what it really means. All right, so let's take a look here. So basically, the CDC put out some new guideline on these PCR tests. Those are the ones, right, that went up the nose that were used primarily for most of the first year. This is they're claiming that the CDC now admits that test couldn't distinguish between COVID and the regular flu.
Okay, all I can say,
Therefore,
Mike,
they're withdrawing their emergency.
yeah, all I can say, Mike, is that that's not my understanding of what the CDC put out. The CDC was not, whether that's true or not, it strikes me as, frankly, not really plausible.
Okay.
What they're saying is that what the CDC is doing, though, as far as I know, and why they withdrew certain EUAs for the COVID tests, for the COVID PCRs, is because they're combining flu testing and COVID testing for efficiency into one platform that'll be PCR. So you'll do your saliva. Hopefully they're not going into the bridge of your brain. And get a specimen. And in the same specimen, they'll be able to test for SARS-CoV-2 and whatever influenza strain.
But that one test will be able to distinguish you have the flu or you have COVID. They're not going to say you have one of the two, right?
They're not that. I mean, they are respiratory viruses, but they're completely different species. And I don't even understand the point of that post, and that had nothing to do with what the CDC was saying. Now, people got suspicious when an EUA is withdrawn, but again, unless there's things we're not being told, the reason seemed to be one of efficiency. Now, I'm not crazy about that either, Mike, because if they're going to run them through 40 cycles, are we going to get as many false positive flu tests as we get with SARS-CoV-2 tests? I mean,
so let me put it into my attempt to put some common sense language on that. You and I mean, because of you, we're suspicious of the PCR test because of the cycle threshold. Right. That there were too many, quote, positive tests.
Right, Mike. They could simplify the test and just say, look, we're not going to run. It's not that we're not going to run it through 40 cycles. We're not going to call a positive at anything above 30.
Yeah, I got that. All right, so there's that argument. But let's assume you got a PCR test and your cycle threshold was like 15 or 20 or something like that. Right. You have confidence that test, people in that range, are indeed infected with COVID and not just the common flu. Oh
yeah. But you do raise a possibility.
This post is claiming.
If you're going to put the two tests together, you better know damn well that they're not going to interfere with each other and things like that. I mean, so right. I have those sort of methodologic considerations, but in principle,
can one obviate the other?
No.
Can one obviate?
There are panel tests, Mike. There are panel tests for respiratory viruses that'll look at a whole host of things. I'm sure it can be done technically. What I'm just saying is that they better test it. It better give you a separate result for SARS and a separate result for flu. And then fine, why not? Why not package them together?
I'm sorry, I didn't phrase it. I want to ask you a totally separate, related but separate question. If you've gotten COVID, does somehow that obviate your chances of getting the flu?
Oh, that's another. Well, we don't. That's another in terms of providing cross immunity. Like if you had last year, if you had COVID,
something like that.
There's I'm not aware of any evidence like that. But there. I mean, for example,
flu numbers went down.
It looks like
We know how
yeah,
the flu
but,
numbers.
right, but that may be this phenomenon of viral interference, which has been reported before. In other words, it's marginally related to what you're saying, in that if some forms of immunity that are not specific, that are more generalized, are activated, and they're activated by SARS-CoV-2, then maybe you won't get super infected with something additional. And so there'll be less flu infections.
All right, so I want to give you 30 seconds to wrap up this mandate madness that's coming. We know that the Veterans Association federally is now requiring vaccine mandates. We know that Biden is considering a federal mandate, a mandate for all federal employees. We know that companies are doing it. We know that colleges are doing it. Schools are sort of doing it.
It's up to the lawyers to fight this. It's up to the lawyers to fight.
Yeah, but I'm just saying from a medical perspective.
I'll give you through a personal lens.
Hold on, let me frame the question. From a medical perspective, we have a little bit of an increase in cases because of the so-called Delta variant. The hysteria is growing again in the left and in the media and in government circles. Is there any reason that what you're seeing out there in the real world should lead to any form of these mandates?
No, and the broader context is vaccines that have already reached their peak efficacy and may be on the wane, therapeutics that are being ignored, and really the clinical course of the illness, which in the overwhelming population, free of very serious comorbidities, is a mercifully benign course. Absolutely not. I just want to put it through the lens of my own son, and just how perverse the whole situation has gotten. He's going to be a sophomore at a major Northeastern university, and he had as it turns out, he had an asymptomatic infection he didn't even know about, but it was from his girlfriend. So ultimately, we got him antibody tested. He has a huge anti-spike antibody titer. We also sent him for the only EUA-approved T-cell test. He has T-cell immunity. He was able, ultimately, with our help, to get an exemption to vaccine, but they were still going to segregate him, right? And which we were going to fight legally.
Even though you showed the T-cell and the antibody,
but Mike, to add, just to show how crazed it all is, 90% of UConn is vaccinated. It was a bait and switch. They are now, everyone, vaccinated and unvaccinated, is going to have to be masked all over again heading into the fall. So imagine, and my son he almost succumbed to this. He was getting frustrated and saying, if they're going to do this to me, Pop, I may go for the vaccination. And what are you going to do? He's a big strapping 19-year-old. I can't physically stop him. But he said, wait a minute, I'm immune already. I'm not doing this. He read about the potential risk for myocarditis. He said, why should I take any risk when I have zero risk now for COVID?
Great.
But now it's turning out that they may go through the same segregation nonsense all over again, including the 90% of students that have been already vaccinated at his campus, in a bait and switch where they were told, get the vaccine and life will be back to normal.
Well, that was the whole the whole nation's at a bait and switch. All right, Dr. Andy Boston, thanks again for joining us. We'll have you back very soon. Thanks, Andy.
Bye-bye.
Wow. All right, folks. So, I hope we made a little sense of this confusing situation that the government, the media, the hysteria, again, the media and the left are putting on this. It's not warranted, folks. It's not based on science. They claim to be the ones with science. It's not based on science. This is what we get. We have emotion. This is emotional. The radio show, the journalist talked about Woonsocket. All the other hysteria here. This is emotional. This is people who are just afraid. They have a right to be afraid of a pandemic and a worldwide disease. Sure, you should be afraid. But the data doesn't support the kind of mandates and draconian actions that they're calling for. The vaccine is not a panacea to stopping infections and spreading of cases. We've seen that. The data shows it. We've talked about the empirical examples. Just look at those Texas lawmakers on their airplane. They all were vaccinated, spread it themselves. Vaccines are not, but overall, we have an answer. Between the vaccines of those who need it and should get one, between early treatment and the ivermectin, or whatever treatments we have, and whatever, and if you have to go in a hospital, and with the fact that vaccines really, you hardly ever get really sick and die, we're managing this overall. But vaccines are not the answer. Vaccines alone are not the answer. And we know that masks don't help at all. That's just crazy stuff. But this is what happens when emotions drive public policy. And this is how the left operates. This is what critical race theory is all about. It's emotional. They're upset about the plight of certain people. They want to reach out and blame it on somebody. So they created this white privilege idea, this white supremacy idea. There's no data to support it. There's not even a lot of empirical evidence anymore to support it. It's emotion-driven public policy. That is the worst kind of public policy, and it's just so ironic. It comes from the left, the group who claims that they are the party of science. Well, the only truth to that is they are the party of politics science, not even political science. Political science is legit. Politics, the science of politics, is what's driving this, not science. Next week, we hope to have a special with some lawmakers and a surprise about emergency management gubernatorial powers in Rhode Island. Some things you probably don't know. I didn't even know until yesterday. We're gonna have a special show, I think, on that next week, so stay tuned. Thank you for tuning in to our extra innings edition, our special summer edition, and we will see you, I hope, next week. Until our next session of In the Dugout, Mike Stenhouse out. Good day.